Okay, good evening, everybody. Once again, welcome to another episode of Mondays with Maishi. This is Moshe Norman from Lakewood, New Jersey, all the way from Lakewood, New Jersey, which is at this point completely irrelevant where I am because Zoom is Zoom and we're all in the same room as far as everyone's concerned. But it's nice to see all of you rejoining us. I'm just trying to see if there's any new faces. I think I do see a new face. Yedida, are you new here? Welcome aboard. For those of you who can turn on your video cameras, of course, we appreciate that. And for those of you who can't, we appreciate that as well. But of course, if you can, then it's always nice to see people's faces. And of course, for those of you who would like to ask questions or make comments, please use the reactions tab on the bottom right of your screen and click the raise hand button. And we will be excited and happy to call on you and hear your contribution. Okay, so it's nice to see everybody again. This is the last week that we're going to be doing this for the next few weeks. I think we're going to take a little hiatus for 2-3 weeks in August, and then of course get back either the last week of August or the first week of September. But we have some more exciting guests. I want to welcome and thank Dr. Patricia DeYoung, known as Pat, from Ontario, Toronto, Ontario. So again, like I said, where you are doesn't really matter at this point. But if you're actually on live and you're in Europe or Israel or somewhere down there, then kudos to you because it's way in 3 o'clock in the morning or 2 o'clock in the morning. So good for you. That's real you know, sacrifice on your end. So thank you, Dr. DeYoung, for joining us tonight. Before we start, tell us a little bit about your background in this field and what brought you to this discussion that we're going to have tonight, which is the process of treating chronic shame or shame in psychotherapy. We'll find out if there is a difference between shame and chronic shame. But what brought you, how'd you land here? People have landed in so many different places, and this is such an intriguing topic. And tell me how you landed here.
Well, I've been a therapist for 35 years. And I noticed that there were certain folks who could be in therapy for a very long time and do really hard work at it and who never kind of got better, who were always just feeling so bad about themselves. And it seemed a pretty intractable problem. I also was, as people in this business are, in therapy and psychoanalysis myself. And at a certain point, if you read my first book, there's a story of how I sort of ran headlong into my own transferentially laden chronic shame. And so it was to try to solve the problem for myself and also for my clients to think about what is this thing. So I began to read whatever I could find, things that have been written about shame. I was grounded specifically more in self-psychology than any other psychoanalytic tradition. And it is specifically about narcissism and its underside of shame. So I had a good grounding sort of place to begin to think about it there. But the penny didn't sort of drop for me about how I wanted to approach it until I listened to Alan Shore, right brain psychotherapy. And I realized that the reason that shame is so intractable is because it's such a right brain phenomenon. It's like in that part of our being, that relational, emotional part of our being that is not amenable to logic, right?
Yeah.
And
Yes,
it's very early and it's very attachment oriented.
Yes,
right?
I was going to ask you if you can explain to those who might not be familiar with the right brain, left brain term.
Yeah.
Can you explain what that means?
I use it as a heuristic if people are not that clear that the brain is actually able to be divided so neatly. But the way I use it is to explain the sort of, there's a linear logical way of being in your thoughts. And then there's the more imagistic, associational, relational, emotional kind of way of being that what more can I say about that? I'll just leave it at that, that there's that sort of difference, that the that the right brain takes up a lot of territory, but we don't know a whole lot about it. It's like the unconscious lives there, and dreams live there, and play and imagination live there. And our neuroses live there too, often the irrational fears that we have and that sort of thing. And then there's our sort of conscious rational self who tries to kind of not know about that stuff or deal with that stuff or tell ourselves stories about that stuff that don't necessarily make sense. So yeah.
So the left brain is the logical, concrete brain, and the right brain is the emotional, feelings, intuition, and all that.
Right. And the most, Alan Shore would say, and I agree with him, that the most important kind of connections therapists make with their clients is right brain to right brain, which is the relational feeling understood.
So therapists make the right brain to right brain connection, and that's also what parents in early childhood and infancy,
absolutely, that's right,
or before a child has any sense of logic.
That's right. Yeah. Yep. There are a lot of I make a lot of parallels always in my own mind when I'm working with people. I do think developmentally all the time. I think of chronic shame as a developmentally instigated problem.
So okay. So what I'm hearing you say is that there are, if we're treating a client with, struggling with chronic shame, then there's very likely some etiology or some history in the early childhood attachment in which the child did not feel either secure enough or special enough. How would you describe that?
I think about misattunement. That's the word I use a lot, where a child, in order to feel like I exist, I matter, I am understood, needs to have that nonverbal most of the time, kind of being understood from the inside out, right? Like that sense of being gotten, or the parent holding the child's mind in mind. There are lots of different ways people talk about that. And that when that doesn't happen, the child feels isolated and unsupported and feels bad, right? It just feels bad not to be gotten, to have a bunch of feelings or have something going on, and the parent that you need to get you doesn't. And the bad feelings kind of morph into a sense, because kids have that kind of logic. If I feel this bad, I must be bad, right?
Yeah.
There's something wrong with me. So I generally think that that's the backstory, even if people have no sort of concept of it, because it's not a conceptual thing, because it happens when you're quite small, right? But when I hear of parent-child relationships or family relationships in which there's a lot of hiding and secrets and disconnection in general, then I imagine that there's shame in there somewhere that people may or may not be talking about, may or may not be able to identify, but that is.
A client of mine described his life experience, his world's experience to me today as, I feel badly or I feel guilty taking up space and taking up time and taking up space. He said, in fact, even when I come to you, I know my parents are paying for the sessions, but even when I come to you, I feel badly about taking your time, and I feel badly about taking up space in where I am. I mean, would that be a good description of?
I think so. That's one of the ways that somebody's got a lot of chronic shame going would talk about. Yeah.
And even his voice, his tone is in a whisper. I said, literally within a couple of feet from him, and I usually can't hear what he's saying. So even his vocal space, I guess he feels ashamed of.
Yeah. It's one manifestation, right? Some people show their chronic shame in such a sort of, it's really visible, and other people cover it with a lot of bluster and, like
So would that
pretend that it isn't so, right?
So
and so it looks different, but it's actually the same kind of underneath.
So is that the sort of jolly kind of shame, where a person presents him or herself as very jolly, very taking up a lot of space in order to cover and conceal the shame? or do you mean something else?
That would be one way. Yeah. You can also like be the smartest guy in the room all the time,
That's more
or
narcissistic or yeah.
yeah, what's called narcissism is often a kind of an overblown cover for shame.
Yes,
Yeah.
yes.
Yeah.
Okay.
But you can't touch the shame, right? You can't get close to it in
Yeah.
therapy. Yeah.
I tried sharing the screen before, but I don't know if it worked. But right now, I just did want to show the books that you were referring to. I know that you have the book Understanding and Treating Chronic Shame,
Yep.
which is, kind of tonight's topic. And then there's also a book that you wrote called Relational Psychotherapy.
Yep. That's the
Right?
old one. The blue one is the new one. There are two editions of both books. So yeah.
Okay.
Yep.
So, I hope to get a little bit into the possible connection between these two books, Understanding and Treating Chronic Shame, but also relational therapy, which, what I'm hearing from your juxtaposition, there's something very connected to relational therapy in treating chronic shame, which would sound very logical to me. That'd be my left brain working right there.
Right. That's right. Yes, I was thinking of Tangney and Deering wrote a book about it called Shame in the Therapy Hour, which is a whole bunch of essays from people across disciplines. And
Mhm.
what they find consistent across what everybody talks about is, I can't think of the app. It's something like positive regard. It's something like unconditional positive regard. That's Roger's language for it, but they have their own language for it. But that's what everybody who treats shame realizes you've got to have. You have to have a relationship with a client in which they feel like they are not going to be shamed, right?
Right. I want to actually get into that if we can in a moment, though, because some people are curious and interested in the terminology of chronic shame versus shame. Is there a distinction?
Absolutely.
Okay, so tell us a little bit about that.
Okay, so shame is an emotion. In itself, it is not toxic. It can be painful, but it's the kind of emotion that, again, I go to development, right? If you learn how to work with it, shame tells you that you have crossed a line with another person, right? You have made a mistake that you should be ashamed of. But in normal development, a child is helped to feel an appropriate sized shame connected to an appropriate kind of action. And then they learn how to maybe say they're sorry and not do it again, right? They learn some sort of moral accountability comes by way of a combination of shame and guilt. The two are related, but
Yeah,
they're not
I
the
was going to
same.
ask you. Yeah,
They're not the
because
same.
my understand that's how I understood guilt. Usually the way that I was taught, or that I intuitively understand the difference between guilt and shame is that guilt is something that's more local, and that's not about the self. I
That's
feel
right.
guilty because my superego tells me that something I'm doing ought not be done. But
That's right.
shame is more an experience of the self. I feel shameful.
Yep.
I feel like that,
Yep.
teenager said, I feel like I don't deserve to exist, or I shouldn't, I shouldn't
Right.
be taking up
Well,
space.
that's a chronic shame, right?
So where's the in
The
between?
so the in between is, I don't think it's possible actually, if you do something, the classic thing is to say guilt is about something you did, shame is about who you are.
Yes.
But I don't think that as we actually live life, it's split. You can be separated so easily,
Mhm.
right? I think that it's kind of impossible to not have some twinges of
Shame.
shame when you've done
Feel
something for
guilty.
which you feel guilty, and that those twinges of shame are something that you can learn to process too. And it's important to learn to process.
I see.
In the latest edition of my book, I talk about the cultural shame around the way, for example, Canadians have treated Indigenous folks and the way Americans have treated Black folks, and that there is some kind of ethical shame that we are called to, right? When we have like not been with others relationally that the way that we should have,
Mhm.
which is woven through the sense of having done something as a person or as a group of people that we shouldn't. But the difference between that kind of shame and chronic shame is a difference of in kind. It's not like the chronic shame is more of that. The healthy shame is processable in working towards accountability, maturity,
Development.
feeling good about yourself, because you can say you're sorry and make it up with somebody, right?
I see.
Whereas chronic shame is more a sense of I am a bad person through and through, that's not even connect. Like the guy you were talking to today, he couldn't tell you what he had done, right?
Oh,
Or
he's pretty much
exactly
done.
what's,
He's
yeah,
pretty much done everything right. I mean, I have a lot of,
exactly.
I think I have a lot of respect for him when I hear his true story, and
Yep.
he can't have that same respect for him that I can.
Right.
And I think that's very sad, really
Yes,
sad.
it is really sad. And it's so puzzling, right?
Mhm.
When as therapists, when we're with these folks who really haven't done anything to be so ashamed of, but they're so they've got that shame going down to their core.
I
Yeah.
wonder if it'd be a good case study, as we talk about the treatment of shame. I'd love to hear some of your thoughts, because I think this would be, the work that I'm doing with him is very relational. I generally do very relational work.
Yep.
And I'm wondering if, we could kind of use him as a case example, for how to treat someone with chronic shame.
Mhm.
Let's talk a little bit about that then, about the using the relationship, in the psychotherapy. Again, you've stated pretty much that the assumption is, again, whether it's completely accurate, whether there was a rupture and some trauma at some point, or but overall, the shame is probably or generally coming from having been uh, inferior in some way by others, seen as inferior, or like you said, having been emotionally neglected. Again, you didn't use that term, but
Yeah,
not having, you use the term of lack of attunement, emotional
that's right.
attunement.
Yeah.
So there's a reciprocity that comes with that, right? That the
Yeah.
child smiles, it causes the parents to smile. If the child smiles and the parent doesn't smile, so wait a minute, something's
Yeah.
wrong here with me, not
Yeah.
with
Right.
you, right?
Yeah. Yeah.
And so there's this budding and developing sense of shame.
Mhm.
How in the therapy room are we going to begin to address that?
You're going to be right brain attuned to your client, which means that um, your so now I'm thinking Porges, right? The kind of
That's
ventral vagal, the
polyvagal.
polyvagal, the ventral vagal, the the way you take up space with this guy, right? The way you tune into the way he whispers, right? The way you lean forward, the way
Mhm,
you take up space with him, doesn't override him, gives him a sense that he matters, right? And that's kind of where you start with everybody is
mhm,
finding like how to modulate your being, your presence to best fit them, to best give them some space to become, right?
mhm, mhm,
Um, with somebody who presents so overtly with, I feel so awful about myself, I would begin fairly early on to name this thing that troubles them, to begin to make a little space to be able to think about shame as a thing,
mhm.
right? So it sounds like it's a bit of a trick, but it's not, right? It's like the problem is not that you are so worthless, but that something is telling you, some pattern inside you, some storyline is in you that's telling you that you are so worthless. There's this shame thing that keeps happening to you
Mhm.
that we can begin to wonder where it came from and understand when it makes its worst attacks, right? And how it attacks you and what it tells you, that sort of thing. To get that sort of ego, the gap, to get a little negotiation space, right? It's kind of, people do that around depression too. They talk about my depression rather than the world sucks, right? Or there's nothing to be happy about ever. It's like
Mhm,
my depression is telling me this.
mhm, mhm.
So I am a terrible person. My shame is telling me this.
So it's kind of an internalization, usually often we use externalization with certain kinds of experiences, and over here we want the person to actually look at themselves as the person who's struggling with the depression, rather than that everything else is a problem. Is that what you're talking about? Or
For shame to be a thing, right, is sometimes so mind-blowing for people, right? Like, no, maybe I'm not worth nothing. Maybe I've got this problem called shame. Like,
so you are externalizing, actually.
yeah,
Okay, so
that's right. Yeah,
externalization.
that's right. Yeah.
Okay. Well, what was interesting with this fellow was that uh, for the first few sessions, he hardly spoke at all, and I couldn't fairly gauge his, number one, his intelligence level,
Right.
And number two, his processing level, because he would wait, after I'd ask a question, he'd wait for minutes before he'd answer, and you could see himself struggling
Mm-hmm.
to process and to answer. And it took me a number of sessions to realize that this is actually a brilliant
Mm-hmm.
young man,
Mm-hmm.
very, very cultured, but from a culture that you would not expect it. You should not expect him to be cultured, very cultured, knows a tremendous amount of poetry and classic writings and things like that. And what I found myself doing was kind of giving him many, many options. So if I'd ask him, do you think that this is happening to you because of this? Do you think that your mother or your father or this or that? I'd wait. After a minute, I'd say, or maybe they think it's that, or could it be that? And what I realized after getting to know him a little bit is that I just had to wait and give him more time.
Mm-hmm.
You're talking about attunement. I'm just thinking how it took me a little time to figure out how to attune with him. But at this point, we're a few, I don't know, 2 months in, and what I realized is that I just got to give him that space. And by giving him that space, it's actually providing him with the respect and the time and the space that he needs to sort of come around.
Mm-hmm. Right. And what I'm interested in is whether there's some kind of a mild neurodiversity kind of a thing for him, such that he has always needed that kind of space. And parents aren't like warned ahead of time what kind of kid they're going to get, right?
Okay.
He's always needed that kind of space, and it's been hard for him to get it. And
Right.
that would be one easy way to think about how misattunement happened for him, with it not being anybody's neglect, right?
Mhm,
It was a
mhm.
mismatch between the same as between you and how you anticipated you could talk to this fellow and what
Mhm.
you've now figured out, because that's your job, right?
Yeah.
But it could have been the same kind of mismatch between him and his parents when he was little, and between him and his world right now too.
Right. Well, I have a whole lot more information, at this stage in the therapy, which
Mm.
would be interesting. But I just wanted to encourage anybody who has a question about this or a case conceptualization that you'd like to share. It'd be really interesting to hear what Pat's perspective is on the case. But one of my questions that I have for you is, how common is chronic shame in the patients that we treat? Is this something that's ubiquitous? Is this something that's small percent of who we're treating? And are we really treating a whole lot more chronic shame than we're actually acknowledging? We're treating symptoms of OCD, but we're really treating chronic shame.
Yeah, that's my bias, that's true. That for most people, for most of our clients, it's in there somewhere. And for anybody who has suffered relational developmental trauma in particular, that it's very likely there because of that break in attunement and in support and
Right.
in attachment, right?
Pat,
So with
yeah,
in addictions, for example,
yes,
it is ubiquitous, but then at the same time, attachment insecurity is ubiquitous as well, right? So you don't necessarily have to connect the addictions to the shame as the what's behind the addictions, which are a coping mechanism, right?
mhm.
So yeah.
Okay, so I have so many questions. So one of what many of my students or people who follow the show know is that, and we discussed this a little bit before the show, is that my perspective on neurosis, I guess you would say, is for the most part, that I see a process of conflict.
Mhm.
Okay, a person is in conflict, and then on top of the and everybody's in conflict. If we have anxiety, that means there's two conflicting parts to us. If we have anger, that means there's two conflicting parts. There's a part that needs this thing to stop, and I can't get it to stop, and it makes me angry. And the same thing with anxiety. I need to feel safe and secure, and I don't feel it. And those two things are banging against each other, and it's creating an energy, right? But I think that people don't need therapy, obviously, for feeling anxiety or anger or any other kinds of normal feelings or emotions. But when people do begin to need therapy, it's when they can't accept themselves for having those experiences. And so now, on top of the anxiety or the anger or whatever other conflict that they're struggling with, there's this, and I can't be struggling with anxiety, and I ought not be nervous to get up there publicly and speak, and right, and I shouldn't be, and I so this beginnings or grassroots of self-loathing or lack of acceptance, depending how far we want to take it, that's really when people begin to struggle on a very deep level and come in for therapy.
That's right. And so then my question is, in my mind, I don't necessarily say it, but I'm always carrying it, is, so where did that come from?
Yes, exactly.
Like,
So
where did you learn
that
where did you learn that it's not okay to have feelings?
That's right.
To be anxious, to be angry? Like, how was it that you didn't learn how to process emotions like anger with other people, or share your anxieties and get some support, right?
Yeah, so talk a little bit to that. How is it, because clients will tell us all the time, I had a good childhood, my parents are great, they were fine, which of course is very just general and not really reflective. Some of the limitations in people's parenting is subtle,
Yep.
yet very powerful. Very, so what are some of the attachment limitations that may have occurred that weren't blatant, or easy for the neighbor to see, but may have been present, that may have limited a person to be able to accept him or herself for having the feelings that they have?
Yeah. Well, a lot of people have learned to struggle to be a good boy or a good girl, right? And all kinds of good families want to produce good boys and good girls. And, it can go back several generations as, good boys and good girls don't be angry, or they don't have a lot of emotions, or, you can kind of pick the thing that it's not okay to be.
Mhm.
And it could be under that rubric. Say your question again, because I think there were several answers in my head at once.
Yeah, okay. No, the question was, what kind of parental limitations may there have been that are subtle, that may have limited or shut down the ability for the child to, I guess, the way you're describing now, to have permission
Yeah.
to experience his feelings.
Yeah. I think the parents who are scared of their own feelings, they just pass that on like that, right? Because kids pick that up in an instant. So parents who are afraid to cry, parents who don't know how to manage anger, who experience it as rage and blow ups and stuff, who can't just be clearly angry, I don't like that, don't do it again, kind of thing. Kids pick up from that anger is scary, that making a mistake is a terrible thing, right? Parents who don't know how to help their kids feel comfortable being fallible and mistake making little humans, right? That's okay and we can fix it, that sort of thing. Parents who bring their anxieties hugely to the task of parenting, who haven't cleared out their own business, right? You don't have to be abusive to miss, right?
Yes.
Yeah. You don't even have to be neglectful to miss. You can just be scared of the human beings that your little kids are. Right?
So parents who are not comfortable with their child's emotions, not comfortable to lean in, to support, to hold, to permit, in those cases, the children are going to start learning that we got to get away from this, and that's going to create that double conflict.
That's right. And the parents will have learned this from their parents. Chronic shame is very intergenerational, right? It gets passed down, and you can see from what you just said how that happens. Yeah.
Right. Okay. Let's talk a little bit to the relational piece, to the psychotherapeutic process and the relational piece. You you began by talking about matching right brain to right brain.
Yep. Yep. So
So
tone of voice and gaze and inflection and pacing and not speaking too loudly or too quiet, all these things that we therapists do so instinctively, really, or when we've been in the business for a long time, we do. That's the right brain kind of stuff.
so does it end there? Do we, if we have a client in our room and we treat them with good, very strong generalist therapy skills, is that adequate, or do we want to go
I think you want to
relationally?
go further.
Yeah. Do we want to take it to a relational level where we explore the relationship as well?
With clients who are able to do that, we do. There are clients that who get freaked out by that, right? It's like too much too soon if you say, well, what's going on between us right now? But one of the principles that one of the core themes in the first book is that relational psychotherapy ultimately comes around to the difficulties, the internal difficulties from the past getting played out with the therapist, the whole transference story.
Yes,
right?
yes.
And that's really, really likely with somebody who has chronic shame. It's such a relational malady. You're going to think when you're sitting over on that side, the therapist is thinking ill of me, right? The therapist has all these judgments about me. If the therapist drops the ball, it can be a terrible wounding, right? And so we have to be, as therapists, aware that our shame-prone clients are so narcissistically vulnerable, right? Can be so easily hurt by us, and we'll have so sensitive, and we'll have to have us attuned to that and willing to work those things out with them, like in detail, right? So that breaks and repairs, which are important in psychotherapy in general, are particularly important in working with people with chronic shame. The thing is, often they won't tell you about a break because they're going to think, oh, I messed up, right?
Or they don't feel entitled, or they don't feel entitled to take up that space and say, there's me here.
That's right.
They're not going to bring in the me. I actually, with Mike, the client that I was discussing before, a number of weeks ago, he was telling me that one of the, when he was describing his experience in the world and how he's so scared to hurt other people and to take up space in that way, or to insert himself in a social conversation, because, like, how does he have a right to, who said he'll be saying something meaningful or important? And I reflected with him at some point that I actually find myself, he's so scared of hurting other people, and I said to him that I actually find myself afraid of him. And he said, well, what do you mean? In other words, he was kind of stunned because he's so careful to never hurt anybody. I said, well, I find myself afraid of you because you present us so sensitive and delicate that I'm afraid that I have to be mindful or careful of every word that comes out of my mouth not to hurt you. And that was actually a great, I don't know if that's something you would condone, but it actually was a great therapeutic moment for both of us. I was able to say this very sensitively, but at the same time, while at the same time sort of reflecting on him, that where he feels he's being so sensitive and gentle to others is actually creating that people are afraid of him.
The only thing I would, when you said, I don't know if you would condone this, the only sticky part of that might be that he comes away thinking, oh, I made him feel bad.
Yes. And I'm very okay with that, because based on where we were at in the relationship, I felt that if that occurred, then that's a rupture that will repair. But I would prefer that to having to be careful with him, and then resenting, being so overwhelmed when he comes into the room, and resenting him, that I start to develop some negative feelings towards him. I'd prefer to be open.
Right. So from my very shame sensitive place, what I would be sure to do at some point, not too long after that, would be to say, how was it for you when I said that?
When I said that, right.
Okay,
Exactly.
great. Yeah.
To open up that relationship.
Yep.
I would consider that, using my I would consider what I did using my countertransference
Yep.
to sort of inform him or reflect how he makes in his it's kind of like that anxiety pattern where we
Mm,
become anxious about something and then we become more anxious because we're anxious and we have to get rid of the anxiety, right? That
right.
anxious pattern. So
Right.
in this sense also,
So what I'm wondering is whether you've also sussed out something about a parental pattern that led to his chronic shame, which was that maybe he feels better when he knows what's going on with you. And there was too much not knowing what was going on with parents.
well, he actually, it's interesting that you mentioned that because the way he describes his experiences, he said that he it's very hard for him to engage with new people until he observes them, until he spends time figuring out what it is that they're going to want him to say or what it is that they're going to want from him. And in
Mm,
that way, he can then engage them because he kind of so I asked him if he does that with me as well. And we
yeah,
kind of chide about that
yeah,
often. But we then, of course, led to a discussion of his parents and,
right,
which is very fascinating.
yeah.
He described that his father um, was, I guess, enmeshed with him and used him a tremendous amount because the father found a lot of similarities between him and his son, especially
Mm,
in their intellectual pursuits, which the
mm,
father has himself felt very um, sidelined or alone, from
mm,
other people. The father is again also very highly intellectual and has intellectual interests and was never fit into the crowd in that way. His son is very similar, and the father
mm,
began to use him, and
mm,
the son became this sort of overblown pride and joy, and
mm,
eventually it caused the son to begin to deteriorate. It was too much pressure for him and to deteriorate, and he describes his experience as he being one with his father. In
mm,
fact, to the point where he said that he's going. I asked him if he has separation anxiety, and he
mm,
said that he's going on a trip this summer for 3 weeks. And I said, "What is it like for you to leave your home?" And he said, "It's very, very difficult for me to leave my home." And I said, "Well, can you tell me what's difficult? Who is it difficult to depart from?" And he said, "My father."
mm,
And when we explored it, he didn't have an answer last week, but he came back this week and said, I think it's because I feel that me and my father are one,
mm,
and stepping away from him is leaving a piece of me behind. It's kind of, and I asked him if he knows why he feels that way, and he basically shared that he feels anxious for his father. That without him there, without him present, his father's not going to know how to cope.
mm. It's like he disappeared in that relationship. His sense of self has not had a
Well,
chance
way
to.
early on.
Yeah,
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 way early on.
exactly. That's right. Yep. Hmm. Hmm. So there is no space for him, right?
Well, right now there is no him. Virtually is no
Yeah,
him as far as
exactly.
he's
Right. No space for a him to emerge, even.
right.
Interesting. Yeah.
Which again, that's great feed for your process, which would be to really create a lot of space for him
Hmm.
in our room, so he begins to become.
Hmm. And also, when you say, when you did this, I had this response, you are being an other who's not enmeshed, right?
When I did
When you said what you said to him, when you did that self disclosure piece, right?
which self-disclosure?
Um, that you said you were scared of him,
Oh yeah, okay, yes,
right? That one.
yes.
It strikes me that you had somehow picked up that he needed to have you be an other that was different from him, that he could bounce off. That's part of what would make a safe place for him then,
Yes,
right? To
yes.
have someone that he's not going to be enmeshed with,
Mhm.
even though his system is moving always to, what do you want from me? How do I give you what you want? Right.
Right, right.
That pull to enmeshment is really powerful in him.
Yep,
But you weren't just going to let that happen between the two of you.
correct. And
Yeah.
and and to
Mm,
further your point, I think, say it even more profoundly, I think that it was really important for him to sense that I can give him that feedback that he and I are not the same,
mhm.
which will create anxiety for him, and to still accept him in that space. So,
Right.
I feel scared of you because I have to be so careful with what I say, and I'm okay with you in that way.
Mm, mm,
But just so that he become more aware of what he may be imposing counterintuitively imposing on other people.
Mhm.
His desire is to make people comfortable, and his terror is to make people uncomfortable. Yet what he's actually doing is, counterintuitively making people
Right.
uncomfortable.
But what exactly he's doing isn't as important in the shame sort of sense as that move that the relational move that you've made, which is there's something that's not meshing really well with us, and I see you for who you are, and I'm totally okay with that. Right?
Exactly.
Yeah.
Exactly.
Mm-hmm. Mm-hmm.
What other relational information do we need to have in treating these clients, this chronic shame, besides just attunement and matching affect and tone and inflection? Anything deeper than that?
Deeper.
Is there anything more in the therapy process that we need to be doing?
Well, oftentimes the transference, countertransference in a longer term relationship with a person who lives with a lot of chronic shame can get to quite a stuck point, because most of us therapists as humans who have for one reason or another become therapists, right, usually have come through some kind of relational trauma, right? We've had to do our own work, and these are the clients with whom there can be an impasse, right? A transference, countertransference impasse, where we feel shamed at some level by them and they feel shamed by us, and we just get stuck there. So it's important to have good supervision around those kinds of things, those kinds of impasses where we feel uncomfortable in the relationship.
Mhm.
And to have some perspective or some anticipation that it's kind of inevitable that we are going to be pulled into kind of shame-ridden enactments with
Mhm.
folks who struggle with a lot of chronic shame. To be prepared to do what one does, to reflect on what the enactment is, reflect what our part of it is, bring it forward as best we can, work it through. Like that really sticky part of transference, countertransference stuff
Mhm.
is very often a part of working with chronic shame. And that's fairly deep stuff, right, for us as well
Yes.
as
Yes.
therapists. Yep.
So there's a lot of self-work that needs to go on in this process
Yeah,
throughout.
I think that if you're going to be serious about working at a deep level with folks who struggle with chronic shame, you have to have done your own work
Mhm.
around your own chronic shame. That's just, yeah,
So can we talk a little
absolutely.
bit about, I'm kind of describing this very, very timid, shy, wishes he could crawl back into the hole, young man. But we know that chronic shame can manifest, like we said earlier, with in narcissism, and that's a whole different client that you're treating. The one that you kind of feel really badly for, and you feel really anxious around, and you kind of want to make him feel better, right? The one who brings that out in you, versus the narcissist who you kind of want to stop and put in his place, or I don't know, some other reactions that therapists might have.
Mhm.
What would how do we shift gears in the treatment? I mean, can we also work with those same premises, or is there something different that has to happen? Need we be more firm with somebody who's presenting as aggressively narcissistic, um, or is it the
Yeah,
same thing?
I don't know that firm. I mean, firm as in to hold your own and not to be pushed around. That's always important with anybody. But mm, the for me, the tell for a narcissist is somebody who tells stories about all the people in their lives who are doing them wrong, or who, right, who
Everyone else is a
misunderstand.
problem.
If everyone else is the problem, that's right. And it's a very long haul to sit with those folks and to listen for the vulnerability, right, to hover, to be on side with their experience while not sort of agreeing with them that everybody in their life were terrible people, and to that sort of getting back to, and how did that make you feel, and I hear that was difficult for you, and to help them like begin to self-reflect and to hear with a lot of space around it, the moments of little vulnerability that come a bit at a time. That's the only way I know how to do that kind of work. The challenging just often gets their backup. For me, the thing that I have to hold in mind is that in spite of all of the bluster here, they're here for a reason. Something's hurting them. And if I try to stay attuned to what might be hurting them, the part of them way inside behind this, I'm great and everybody else is messing up, that's here, that wants some help and some understanding, is like listening. And I'm talking to that part, and we will slowly get there.
So you're seeing the narcissist as wounded. Excuse me. You're seeing the narcissist as just wounded, and another form of the same process.
That's right.
Okay.
And dissociated really well from their own shame, right?
Yeah.
The shame's motivating a lot of how they be in the world, but they have
That's
no
an interesting
idea.
point, because the timid, shy person is going to run and jump right into the admission of the shame, and the narcissist is going to deny the shame. So that's a whole process or stage of the therapy, possibly even before preempting this process.
With the narcissist, it preempts the process because
in other words, the narcissist is still 2 steps behind in admitting the shame. Okay, let's take a question from Daniela. Go ahead.
Toxic shame, is that the same thing that we've been discussing as chronic shame, or would you say toxic shame is something else?
I'd say it's pretty much the same. That was John Bradshaw's language for it quite some time ago. And I find myself, feeling like I'm playing in the same ballpark as he was.
Okay.
Yeah.
And then I work with a lot of with survivors of sexual abuse. There's, a lot of shame in that population. I was wondering, is there anything, do you have any specific recommendations for working with that population that would be maybe different from the general population that you could share?
Not anything specifically different that comes to mind. I think one of the things that I've come to realize over the years is that the actual things that happen to people when they are abused may be exquisitely, horribly shameful, painful, right? To remember, to talk about. And that I don't believe that pushing somebody to re-experience that shame and pain is necessarily healing.
No, of course not.
If people want to go there, they can, but that there's another kind of shame and pain for almost everybody. That the abuse doesn't happen in a vacuum. It happens in a network of relationships that have failed them, usually, right? There's a heartbreak about not being seen, not being loved, not mattering, right? And then these things happen in that context. And for me, that's what I try to tune into, that relational kind of pain that's underneath the pain of the events, the abuses that happen to them. So in a way, what I'm saying is I try not to treat them specially because of what's happened to them. I
Right.
try to treat them like anybody who
Right.
has been relationally bereft, abandoned, traumatized by not being cared about, right?
Right.
That's the underneath worst thing that happened, even though these other things are terrible also.
Right.
Make
Well,
sense?
would you say, Pat, that most victims of sexual abuse are people who are vulnerable to chronic shame? So they kind of either can't put a stop to it, or they are vulnerable to getting that attention, that being groomed. Is chronic shame synonymous in some sense, in some way, with sexual abuse?
Hmm. I wouldn't say that chronic shame is an internal thing leads to their being sexually abused. I would say I think a lot more in terms of systems, right? Or in terms of the relationships in which they are embedded. If these things are happening to them, they are already inside of systems that make them feel like they don't matter.
Right.
So you could say, their chronic shame is the problem. I would say that the systems in which they live, which tell them in so many ways that they don't matter,
Mhm.
is the primary problem that then leads to, they can't say no to it, but the system does it to them too, right? Leads to
Mhm.
them being sexually abused, physically abused, other kinds of overt abuses that aren't just that aren't emotional abuse
Right.
only, right?
And so would treatment of sexual abuse be adequate? I'm not sure if this is what you were saying before, but would it be adequate just with a very, very strong, deep sense of acceptance and attachment from a therapist, without actually indulging in the stories and the memories?
I wouldn't push for stories and memories.
Mhm.
I would offer the strong, deep attachment and the being willing to be there for whatever comes forward, whatever needs to be spoken, whatever needs to be processed, and accept wherever the internal limits for that person are about,
Mhm.
I need to talk about this much, but what I really need is not for you to look at me as an abuse survivor, right? But to see me as me, the person that I am, right?
Mhm. Mhm.
The person to whom these things happened.
It's interesting. Interesting. I did hear from an expert once on child sexual abuse that she said it's not even always necessary. It's not always necessary to talk about the story or even identify whether the child was abused, because the predominant nature of the treatment is going to be to secure the attachment, to hold strong boundaries, and all those things. So if the therapist is doing that, then it's not, we don't always get to find out everything that occurred in
Yeah,
our clients' lives that affected them.
that's
And
right.
so she said, when working with children, they may not fess up, they may not understand what happened to them, they may not recognize that there was something inappropriate that occurred with them, but you can still work effectively, excuse me, to heal them, just through that strong attachment.
Yes. And I think that the same goes for our adult clients who were
Yeah.
once those children, right?
Yes,
That,
that's true.
that yes, they don't have to remember to be healed, but they do need to feel like they are loved and they matter in order to be healed, right? Those are two different things.
Okay, let's take another question. Thank you, Daniela, from Devora. Go ahead, Devora.
Hi, Dr. DeYoung.
Hi.
I It's also interesting. I'm curious what your thoughts are on, you mentioned sort of this idea of providing like a safe space for the clients, with all their shame and acceptance. And I'm wondering how you would work with clients who don't respond well to that approach. I've had clients who almost recoil at that, like, and there's the transference. I've had clients who, in the transference, have told me something really shameful. And when I've responded with sort of acceptance and, trying to normalize something for them, they've come back to me almost, one client, there was, a lot of transference for him in that he was actually really upset with me that I had that reaction, and that, that I was so accepting. He didn't want me to be okay with it. He wanted me to, not accept it. And, because that's sort of what he is used to in his, in those early primary relationships. And that's almost, I work from more of an analytic approach also. So that's, what he's, that's what's comfortable for him. And that, so it was very sort of upsetting that I was so accepting of this shameful thing that he disclosed to me, and I've had other clients also where they can't tolerate that level of acceptance for their shame. So I'm wondering what your thoughts are on that, or how to work with that.
Mm-hmm. So I have on two different tracks. And one is somebody has told you something that is very shameful and you're accepting of it, and they want you to agree that it's very shameful. They right. And then maybe another track, I don't know if it's the same thing, is somebody wanting you not to, for example, tell them, not that you would do this blatantly, but any kind of seeing them differently, seeing them whole, seeing them as the people you wish they could see themselves to be, right? If you offer that too soon, it feels like, no, you're not understanding, right? You don't get how bad it feels to be me. This is the truth that I live with. I need for you to get that this is my truth, that I am ugly and smelly and worthless and I don't matter. I need you to be inside that with me. I can't handle you telling me too soon. I mean, it's interesting because I've had clients who said to me after a while, I do need for you to have that other view of me. I can't hear too much about it, but I need for you to hold it for me anyway, right? But maybe that's a little bit different question than the one of somebody who's told you some particular action they're ashamed of and they want you to.
Right. So I think the first that you just mentioned is definitely one of my clients who can't, needs me to see him the way he sees himself. And that, I can hold that sort of vision that I have of him that, he can't tolerate yet. But I think, the other one is, a client who almost, expected me, wanted me. It was, part of his transference. He wanted me to almost recoil or be ashamed. And he even sort of said to me, well, would you be okay if one of your kids told you this? Like, he wanted the reaction almost. He was looking for that reaction that he would have gotten from his parents, or,
Mm-hmm.
and, he was upset with that.
So did the two of you explore that phenomenon? I mean, it does open those things if you just stay curious, right? They open into more understanding of kind of what he's up against, how big this thing is that he's up against.
Right.
Right. That there's something in him that wants you to respond the way his parents did. And it's powerful. And he's not able right yet to hear anything different. And that's a thing, right?
Yeah. So do you find sometimes with shame, I guess you have to sort of really, see where your client is in terms of what they're able to tolerate and what they're able to, in terms of how you can react to, how you can deal with the shame or help them deal with it.
Yeah. And I like to put it out there on the table with them, right? So that I'm not over here trying to sort out, okay, what is this person shame like? What can I do with it? But to say, isn't it interesting that you said this and I said this and you had this reaction and now I'm having this reaction, and can we talk more about what that's about, and where is there any give here, or how solid is it? So you just talk about what is. This shame thing is huge. And it's powerful, and it's been running your life for a very long time, and it's got its rules, right?
Mm-hmm.
Yeah, something like that.
And some clients expect you, to shame them. They're almost not
Oh.
comfortable. Sort of like Deborah was saying, they're not comfortable. A client of mine said to me this week, he said, I want you to be tough with me. I want you to be hard on me,
Mm,
you know? And of course I explored that with him. What do you need me to be hard on you? You're hard enough on yourself, but
mm.
that's besides the point. But what does it do for you, for me to be hard on you? And it kind of creates a certain comfort and safety, that he is as shameful or worthless as he is supposed to be.
Mm. Mhm. So again, I would say that's something to, not to, you can't cut across it, right? You can't, you have to accept that that's his package of shame. That's how it works for him. That's how he walks through the world, that he needs people to think that of him. And then what? Or what's behind that? Or what more can we talk? What more can we say about that or explore about that? What would happen if you did believe for a moment, or if you let the thought in that maybe you were, how would that make, why would that be a bad thing, right? What's the bad thing that would happen if I didn't give you that?
Mhm.
Right?
And so leads to another phenomenon of clients, also some clients that I could, generic clients that I can think of in the past, maybe even one who I'm working with currently, where they'll self-sabotage because they have to constantly be in a state of shame. They're so familiar with having been shamed or put down or failed in the eyes of their parents, that they will literally avoid being successful. And the comfort and the familiarity of being shameful causes them to sabotage their lives.
Well, that's one way to think about it. Another way to think about it is, how dangerous is it if humiliation has been a huge part of your early experience, that you would start to believe that maybe you're okay, that maybe somebody likes you, that maybe you're worth something, and then the bottom falls out.
That's right.
That's worse. That's worse, right? Because that's the original trauma. It's way worse than just keeping on failing quietly, right? And never, don't hope, because that's going to be the death of you, right?
So it's like the quote that they say from Mark Twain, I think it was. He said, better keep your mouth closed and have people think you're a fool than to open it and remove all doubt.
Right.
So people would rather stay in the safety, or the comfort, I should say, familiarity and comfort of failure, than to actually actively try and fail.
Well,
There's
yes, right. Because the failure is so painful, because they have failed all alone. Like, that's the relational piece again. Nobody's caught them and said, hey, that's okay. You can stand up and try again. When you're small and you're alone, even when you're not so small and you fail, it's like just free falling, right?
So I'm wondering how, I actually find those clients to be particularly frustrating. Because for some reason, with many of them, identifying and exploring what the pro-social behavior, or the everyone has a different term for this, but what the pro-social or the motivation to fail doesn't seem to be adequate. And even processing the past traumas doesn't always seem to be adequate in repairing this. They just stay stuck in this rut of refusing, procrastinating to succeed. And I'm wondering if you have any insight on how we might treat someone like that.
You really have to get inside how terrifying, how utterly scary it is to stick your neck out and then in the anticipation of getting humiliated again. Right? It's the humiliation factor, I think, to understand that burn, that intolerability, right?
With some of these clients, after we do all that work, I find that there's actually a reparenting process that can occur, in which you can actually be an encouraging parent and say, I think at this point you might be ready to try something. What do you think about that? And there are clients who will be receptive. Again, it's all about timing. You have to see them contemplative enough and safe enough with themselves to be able to say, and this, it's pretty rare that I'll do this, but with these clients who just seem so helpless, to be able to say, I'm getting the sense that you might be ready to try something. Would you like to try it? And then they'll.
And what, relationally speaking, what you're also saying without saying is that I'm here. I'll catch you if you fall.
I'll catch you if you fall.
Yeah.
Right. So that's where the timing comes in, where the client has to feel supported enough.
Yes,
by the
has
therapist.
to actually believe, has to have that right brain experience of this therapist will catch me when I fall. I know that. That's what they do. Yeah.
Okay. Any questions from the participants? Case questions or theoretical questions? Okay. What else in your book, Relational Therapy, stands out that's significant that you could share with us? What other ideas or concepts?
Well, that therapy is fundamentally an ethical process, not a scientific process. It's fundamentally a connection between human beings that without getting kind of woo-woo about it, right? That has sort of irrational healing happens from the process of being connected, from the process of finding somebody who actually gets you and is willing to go the distance. Right? Yeah.
But when you say the word irrational, do you mean that it's not rational? Do you mean that it's actually irrational?
It's irrational.
Okay.
It's not about reason, right?
Okay.
Yeah. It's about, that right brain connection.
So that's really what the emphasis is. The emphasis is that real effective treatment is through less through verbal information, certainly less through psychoeducation, and more about the connection, so that the person feels, I guess, what the opposite of shame would be, which I would say accepts. Would you call it acceptance or self-acceptance?
Yeah, and I think that a lot of modalities of psychotherapy know this, right? Yes. All of your good therapists, whether they do CBT or IFS or whatever they do, the good ones know how to connect, right? They know how to get the person that's opposite them. And would we all agree that that's the main ingredient to effective therapy? Well, they've been saying that for years, right?
Yeah.
Right. What are they called? The non-specific factors, right? Yeah.
When you can't put a finger on it, it's really hard to, it's really hard to quantify it. Okay. Let's take a question from Rena. Go ahead, Rena.
Hi, thank you so much. I really appreciate the presentation. I wasn't here for the entirety of it, so I hope that I'm not touching on something that you already mentioned. I have a client with chronic shame. I was wondering what your thoughts were about shame exposures.
As in that you would encourage them to go into situations where they would feel shame? Yeah.
You mean the therapist would make fun of the client?
Well, what we do now is it's a lot. The therapy session causes a lot of shame, so we record it and she listens to it after every session. Or we're doing different things to almost, create the shame.
That's interesting. Well, the therapy session actually is creating the shame without you having to work at it, because she's got that much chronic shame, right? Right. So I don't know how I feel about making somebody feel worse on purpose in order to feel better, but I really do believe in paying really close attention to how bad somebody feels, right? In a therapy session, for example, or telling you the story of this lunch they went to and they just felt like they made a horrible mess of things, like to really get down into it and be able to have somebody get how awful it is, right? So to me, the shame exposure is not so much about the exposure, but it's about being really real in yourself and with another person of, this is my shame and this is what it does to me and it is this horrible.
You would say like that and validating that as the client's experience.
Yes, that's right. Yep. Because that's a validation of a core experience that it's very hard for them to get validated anywhere else, because anybody else is going to tell them, it's okay. You're fine. You're a great person. Like, don't feel that way about yourself. They need somebody who gets that they feel that way about themselves, right? Yeah.
And so much of that is in this sort of spontaneous emotive reactions or affective reactions of the therapist. So like when the client reports something embarrassing or shameful, and the therapist goes, "Oh," or "No, for real," right? So a lot of that carries over. It brings over the information that, "Oh, you sense my shame with me, and that makes me feel better."
Mhm.
Okay, let's
Did
take
that
another
answer your
question.
question? Yeah. Okay.
Dawn, go ahead.
Hi, I'm Dawn. Firstly, thank you so much. I really appreciate it. I know earlier on in the discussion, I've missed like 2 minutes of it, but you mentioned how shame coincides with OCDs and behavioral like addictions and behavioral struggles. So I was wondering, when you would see a client, let's say, with such a struggle, do you normally focus on the shame first, the behavior, or both simultaneously? Like, do you try to fix the behavior first, and if it's a struggle, then you work on the shame, or do you work on the shame first?
I don't go in with an agenda. It depends what the client's bringing to me, right? If they're bringing to me behaviors that they feel upset about and they want to get some handle on, to calm them down, like OCD behaviors or something like that, we can talk about that. But I hold it within the context of, like, just for a person to come in and talk to me about those kind of behaviors is going to be, to a certain extent, shaming. Just coming to therapy for most people is to a certain extent shaming. And so I do all kinds of little counter shaming things about the behaviors, right? About that must be hard, or so how does it help you when to understand the behaviors in the context of them trying to manage themselves as a person in the world, right? That they're not shameful behaviors in themselves, that there's something understandable about this whole system. And that it's driven by some, or not maybe driven by, but that underneath there, I'm not going to push it, but I'm going to be aware and responsive to anything that I hear about, and I feel crappy about myself, right? That this keeps going on. So it's not a one or the other. It's like weaving them back and forth through each other according to kind of where the client is in any given moment. I do think that most symptoms have their roots in a kind of fragmented self-experience, which in my view has usually history in a fragmented self with other experience. So I have that sort of psychodynamic take on the symptomology that comes through the DSM or whatever, right? That something has gone wrong between this person and other people, and it lives inside them psychodynamically, uncomfortably, and it comes out as those symptoms, right? So that's sort of my overall way of holding addictions or OCD symptoms or other kinds of symptomology, that they're indicative of inside pain trying to find a way to manage itself. Does that make sense? Am I speaking to your question at all, Dawn?
I believe so, but just to be clear,
Yeah.
like working on the shame part,
Yeah.
That's more the relational aspect, where the way you respond and the way you accept them, which could happen
Yes.
It's interwoven with working on the behavior.
That's right.
So
there's two ways of working on the shame part, right? The working on the shame part is in how you be with, right?
Right.
And then there's also, you can work on the shame part later on by talking directly about the shame, right?
Got it. So one's more direct and one's a little bit less, but it's still sort of direct.
Yeah.
Okay. Got it. Thank you. I appreciate that.
Okay.
Is it okay if we take one last question, Pat?
Yeah, sure. Yeah.
Okay, go ahead. Miriam, go ahead.
Hi, thank you so much.
Hi.
So my question is like this. I have a client who's suffering from PTSD, She went through a traumatic childhood, suffered some emotional, sexual, not physical abuse. And she has brought up on like 1 or 2 occasions this kind of shame that she has around sex and around those type of things. And she actually currently works as a sex counselor. And then when the same piece that she's having shame around, the relationships, intimacy, and sex come up in her own relationship, she kind of has a lot of shame around that and avoids it in our sessions. And I find that she's really struggling in that area, but kind of tries not to bring it up in our sessions. We're also working through a lot of other stuff. So I just want to know if she's avoiding those things, if you think that they are something that I should push her to work through at this point, or if we could just wait it out until she feels ready.
I always think that pushing is not a good idea. I think that people's systems have their own sort of timing. And I encourage people to be brave, right? But to also take the time, right? To talk about things when they need to talk about them. Yeah. Yeah. And as a therapist, you know, it's funny what shame can do, but there might be some shame about having the particular kind of shame that she has, right?
Right.
So it's layered.
So I guess it's just interesting because it feels like a more relevant problem in her life right now. And we're working through like smaller, maybe more like on the side kind of pieces when there may be something bigger coming up for her.
And you're wondering how to get from the smaller to the bigger, or?
Yeah, or I guess I wonder how much of it is like my job to kind of like help her in that direction, or if we should just completely wait it out.
I think that if you listen for the vulnerabilities, for the little clues, right, and you pick up on them, then you're sort of doing both, right? You're leading a little bit, but you're leading according to the clues that your client is giving you about what she's available for or what her system can manage right now.
Okay, that makes sense.
Yeah.
Thank you.
Okay.
Oh, I do want to really thank you, Dr. Pat DeYoung, for coming on and joining us and providing this service for us, giving us insight and some understanding as to both the concept of chronic shame and also the treatment of chronic shame, which I find to be really a great refresher in a lot of the generalist skills that we need to be mindful of. Not trying to be too smart, not trying to be too advanced, but trying to be super present as we can with the client. So I want to thank you for coming on and doing this discussion with us.
Sure.
I hope we all learn from it. And don't forget to purchase the book, Relational Therapy. Let's share that again. If we can share that screen so that you can take a look. This is the current edition, Relational Therapy.
Yep, that's the current edition. That's
right. Here is an older edition of Understanding and Treating.
No, that's the current edition of.
Oh, this is the current edition too?
Yep, you got both current editions. Good for you. Yeah.
Okay,
yep.
Saved me from shame.
Right.
Okay. So everybody do. And if you would like to get in touch with Pat DeYoung, she's very easy to get in touch with because her email address is right on her website, which is, I think, patriciadeyoung.com or something.
PatDeYoung.com.
PatDeYoung.com. And drop the Trisha.
Yep, exactly.
Okay. Well, thank you again and have a good night. We're going to stop the recording.